session today, Let's Code Together. My name's Jane Knight and I'll be one of your co-presenters. I'm also joined by my colleague, Dr. Carol-Ann Wilson, who'll share the session with me.
Hello, everyone. Good morning, good afternoon, good evening.
Thank you, Carol-Ann. So let's go through the introduction. The first slide explains that MEDRA came about in the mid-1990s. It was an ICH initiative, and at the time, the MSSO was put in place to maintain and distribute MEDRA. The activities of the MSSO are overseen by a steering committee with representatives from across the industry, both regulators and industry representatives, and a few of these are listed on your screen now. The copyright is that MEDRA is owned by ICH, as is the material you see today. So if you quote it or you use the material and the content in any way, you must acknowledge ICH as the owners. We want to make it interactive today, so please use the questions panel to ask questions or to put your comments, and we'll stop and read them out. Sometimes it's the case that we don't agree on the term selection, and in the interest of time, we have to agree to disagree and move on. We can't take questions today that relate to specific verbatims that you may want us to help you code, but at the end, there will be an option for you to propose either topics or specific examples for us to consider for future sessions. The next session of Let's Code will be in January now, but if you do this, please make sure your example is of general interest to the wider audience. So I mentioned there's going to be polling. This is how you participate in the polls. You open up an internet browser. The easiest way to do this is on a cell phone by scanning the QR code that you see, this QR code on the right-hand side. But if you prefer to do it on your computer, you can open an internet browser and you go to, in the URL panel, you type in polev.com. Nothing else, just polev.com. When you see the right-hand screen, you enter my name, Jane Knight 855. So it's completely anonymous. You don't put your name. You need to put my name, and that links you to the presentation today. Then you can join. And if you have problems during the session, press the refresh button on your phone. If you're doing it on your phone, refresh your screen and it will reconnect you to the poll if you do lose connection. And on every slide that we poll, there will be the QR code that you can scan. Some of you have found that already, I see. Our first question is, where are you joining from today? Where are you joining us from? And I can see India, across Europe, South Africa potentially, I think, just off the coast there.
India,
Indonesia,
Turkey,
North America, United States, welcome.
Calimera, buenos días, buongiorno, guten Morgen.
That's great. Look, so many of you. Well done. Thank you, Carol-Ann, there for welcoming everyone. So welcome wherever you are in the world. We're very, very welcome. This is the demo password for the web-based browser. You also see in the screenshot on the left how you can access it. You go to how to use, tools, and then on the right-hand side, you can open. This is the link for the new web-based browser. There is a legacy web-based browser link there as well, if you're more familiar with that one. And here are the credentials, but we're going to use the new browser today. So challenges in coding, there's not always an exact match when you try to code. I think we're all familiar with that. Sometimes there's more than one possible approach to coding, and even the points to consider document offers options in some places, a preferred approach and an alternate approach. Sometimes it's the case that we understand a term differently. So what we do when we code, Carol-Ann and I like to say, we're representing the events, the best approximation. We're choosing the closest LLT to represent those reported events. Overall, we always code as reported. We don't make assumptions. And you know, if you've been to on this session before, we always try to bring a picture along. This one, I think, illustrates nicely that sometimes when our brain sees something, whether it's a picture like here, or whether it's in a verbatim term, it's very hard to unsee it. Once I have something in my head, I can't not see it. When I look at this now, we're a bit of a belated Halloween, I think, here in the theme. I can't help but see the picture of the demon's head on the underside of the great white shark. So this is the kind of thing. It's very hard. And sometimes a second opinion is useful. Sometimes I'm not even sure if I can trust the way I see a verbatim term. This one, I'm not sure if this one's working so well today. Do we all see the terms in the same way, I ask myself? And that's what we can discuss in sessions like this. Who would be right and who would be wrong? The point, this one is when you look at something, you think it's blue, and then when you look more closely, the dot almost turns purple. So can we actually trust our own understanding in the way the same as can we trust what we see? It's a balance between applying rules for judgment, rules for consistency, medical judgment to manage the risk. We'll use medical references today to illustrate the importance of references to help us understand the report and make a decision. And occasionally you'll find that the concept you're looking for isn't actually in MEDRA, and so it needs to be added. And you can submit a change request to ask for that term to be added to MEDRA. So that's all of our background. And having said all of that, I'm going to turn my camera off so that it's not so distracting for you. And let's code together. I'll hand over to you, Carol-Ann, for the first couple of examples.
Thank you, Jane. Do you see my screen now?
Yes, I do.
Perfect. So here's the first example for today, which we were unable to cover in the last session due to time constraints. So it was carried over to this session. It relates to body temperature, and in this case, an impaired temperature regulation is reported. Do we know what exactly happened to the body temperature here? Is the verbatim describing a test result or a diagnosis? Could this even relate to an inappropriate temperature for medicinal product storage? Well, I think it's quite improbable. If a fridge does not function as expected, one would describe this fact with non-functioning or failure, maybe not with the attribute impaired. So what would be the most appropriate LLT in your opinion? Body temperature abnormal, feeling of body temperature change, temperature intolerance, temperature regulation disorder, temperature perception test abnormal. I see you voting. What would be, look at the verbatim, try to be as close to the verbatim when searching for terms, but also check the hierarchy, whether it's really actually correctly represented in the MEDRA hierarchy, what is reported here. So let's see what you're going for. Most of you are going for temperature regulation disorder, but others also to body temperature abnormal. So let's close the poll and look at some references. So thermoregulation is the maintenance of physiological core body temperature. And this is the term, the medical term for the regulation of the body temperature. Thermoregulation. It refers to the maintenance of the physiologic core body temperature in order to balance heat generation and heat loss of our body. And the range is really quite narrow. Body core temperature is kept at 37 degrees Celsius plus minus 0.5 degrees. Because the body's metabolism and all the mechanical processes depend on an optimal, so to say, operating temperature. And the body's control center for temperature regulation is the hypothalamus. So let's check in the browser. Let's look for the terms that we had in the browser. So I will use the new web-based browser. Let us log in. These are my credentials here. And here we are. So when I search for a text, so the first LRT that was in our poll was body temperature abnormal. Here we are. If I click on the term and say open details and occurrences, you will see that body temperature abnormal is considered an investigational result. Same PT, it's grouped under HLT, physical examination procedures and organ system status. So it's considered an investigational result. And the same is true actually for the other term that was available in our poll. It was temperature perception test abnormal. Here it is again, open details and occurrences, and you see again it's an investigational result. It describes a neurological diagnostic procedure. It does not describe a disturbance of central temperature regulation, but rather an abnormal test result for the peripheral thermoreceptors. Next one was feeling of body temperature change. I always have to check whether I have a typo in there, but it's okay. Feeling of body temperature change. Again, right mouse click, open details and occurrences. So this one is grouped under general disorders and administration site conditions. So feeling of body temperature change is just a feeling of the patient, grouped under HLT, feelings and sensations, NEC, not elsewhere classified. It's not an objective finding. Temperature intolerance was the next one. Again, here we are, right mouse click, open details and occurrences. Same PT, it's grouped also under feelings and sensations, NEC in subgeneral disorders. So again, it represents a subjective feeling of the patient. It's grouped under the same HLT as the previous LLT, feeling of body temperature change. It refers to heat or cold sensitivity of the patient. And now the next one, and most of you voted for this one, it's the temperature regulation disorder. Here we are, open details and occurrences. And here you see it's grouped under general disorders, under body temperature altered, and also has a secondary linkage to hypothalamic and pituitary disorders, NEC. So you see this represents a diagnosis here, temperature regulation disorder. Let me switch back to my slides here. So when you look at such a term, always distinguish between abnormal investigational findings and recognized clinical conditions, so diagnosis. Use the wording of the verbatim for your search, and when using a different wording, do not add or subtract information, do not interpret. Be as close to the verbatim as possible. And if you see that demographic information makes a difference for the reported condition, then try to get additional information from the case report, because we just only looked at the hierarchy of our terms. But if we would now have a right mouse click on the term here, temperature regulation disorder, and say go to browser, and we would just click on it, then we can see the PT in its hierarchy. And often it's really recommendable to look at the potentially appropriate LLT and PT in the hierarchy. You see temperature regulation disorder here. We knew that it's grouped under HLT, body temperature altered. But when looking at the siblings, at the sibling PTs here in this HLT, you see there is a PT disturbance of thermoregulation of newborn. So there's a demographic information in here, and there is a difference on PT level between the temperature regulation disorder and the same condition in a newborn. So for this term, we would need, in order to really code as specifically as possible, we would need additional information about the age of the patient, of the affected patient. And here we are. So our final suggestion is to check whether this report refers to a baby. Then, of course, we would select the specific term that would capture the fact that the newborn was affected by the temperature regulation disorder. Otherwise, we would select LLT and PT temperature regulation disorder. Are there any questions, Jane?
No, Caroline, no questions on that one so far.
So then let's continue. The next verbatim also refers to body temperature. So what is reported in this case? Is it, again, an investigational finding or a diagnosis, a disorder? Is it abnormal that the temperature is up and down regularly? And can we find a suitable LLT for what has been reported? What would be your approach to this verbatim? Would you go to body temperature abnormal, fluctuating fever, body temperature fluctuation, feeling of body temperature change, spiking temperature, or temperature regulation disorder, as we had in the last example? Body temperature up and down each day. So let's see what you're going for. Body temperature fluctuation is the preferred option. Feeling of body temperature changes also, or temperature regulation disorder. So let me close the power and again switch to the browser. So here we are. One of the terms, the first one was fluctuating fever. Of course, there is one here, fluctuating fever. It's grouped under pyrexia. So, and if I look into, let me close this window. If I look into the browser, go to browser. Here we are, fluctuating fever. You see in a pyrexia, we have quite a number of different LLTs, fever chills, fever of unknown origin, also this fluctuating fever. But fever would be a diagnosis, and fever was not reported. What was reported was body temperature up and down each day. So it would be an interpretation. We would add information when selecting the LLT fluctuating fever. Body temperature fluctuation. Most of you voted for this one. Body temperature fluctuation. Go to browser. Let's see where this one is grouped. Here we are, same PT, body temperature fluctuation. It's grouped under physical examination procedures and organ system status. So it's considered an investigational result. Feeling of body temperature change. Oops. Search. Here we are. If I look at it, open details and occurrences. I'm again in the feelings and sensations, NEC, HLT. So this would represent the feeling of the patient. No feeling of temperature change, no feeling of temperature change was reported here, but a result of a physical examination, a temperature fluctuation. It was measured. Spiking temperature was another option. And you will see, if we go to open details and occurrences, it's again grouped under pyrexia. So again, it would represent a diagnosis. This was not reported. And temperature regulation disorder would also be an interpretation. It was correct for the first example that we had, but here we don't know why the temperature was fluctuating. We don't know whether it's a regulation disorder, so a central regulation disorder, or whether, I don't know, the device measuring the temperature, for instance, was just not working correctly. We don't know. It's just an investigational result that shows that the temperature of this patient was fluctuating. It was an investigational result. So let me go back to my slides. Again, always distinguish reported lab results, investigational findings from medical conditions and diagnosis. If you look at such a term, do not immediately split code, but search for suitable terms that potentially captures the increase and decrease, the fluctuation of the body temperature in this instance. And always check the hierarchy of potentially suitable terms to make sure that you are on the right track. This is one of the really basic MEDRA coding rules. We've addressed some additional verbatims describing abnormalities of body temperature in the last Let's Code session as well. If you were attending, you may recall. And here's a summary to clarify the different background of related terms. So first, the patient may have feelings about his or her body temperature. And you can see some related LLTs on the right. Feeling of body temperature change. We saw this one in the recent example. Feeling cold, heat intolerance. These are feelings of the patient. Other LLTs represent investigational findings, measurement of body temperature, or test for temperature perception, like body temperature abnormal, temperature perception test abnormal, temperature difference of legs, for instance. These are investigational results. And other LLTs represent medical diagnosis related to the body temperature, or abnormal temperature perceptions like cryesthesia, so sensitivity to cold, measured, so a diagnosis of sensitivity to cold, thermohyposthesia, and temperature regulation disorder. These are medical diagnoses. You won't find them in SOC investigations, but under the other SOCs representing organ disorders. So make sure to distinguish between these concepts. And with this, here our final suggestion. We would code to LLT and PT body temperature fluctuation, and most of you voted for this LLT and PT. So well done. Any questions, Jane?
No, only a couple of comments from Martin that to explain that people's temperature does vary during the day between moist, so it's quite a normal thing, not necessarily abnormal. And he's given us a nice article from PubMed to illustrate that, where it's been done on a large scale, monitoring it.
Yeah, but still, as I said, when discussing the example with the temperature regulation disorder, the body temperature is kept quite narrow, so 37 degrees plus minus 0.5. So this is usually the correct margin of body temperature.
We have one more comment here, Carol Ann. Let me just find this one. That let me find the question. Wouldn't coding impaired temperature regulation as a medical diagnosis count as interpretation? Well, on this example, I think if you're referring to this example, we didn't choose it on this example, but if you mean the previous one, let me know and we can address that one on the previous example.
So the previous example really referred to a regulation disorder, whereas here it's really the body temperature that was measured and it went up and down each day. We don't know to which level, but it may have been fever in the evening and a normal temperature in the morning, but we don't know. It's just a body temperature fluctuation.
It was the previous example, Carol Ann, that the comment referred to.
So let me switch to the slide. Impaired temperature regulation. This is really not an investigational finding that you can see here. It's a regulation disorder. So it's not referring to a measured temperature, but it's telling us that the regulation of the body temperature is somehow not working correctly. So it's a diagnosis. Sometimes it's really difficult. We will have another example today, Jane will present it, where it's also difficult to distinguish whether this is an investigational result or a diagnosis. But here I think it's quite obvious that it's really referring to a diagnosis and not to a measured investigational result.
Thank you, Carol Ann. That's all the questions so far.
Okay, then I hand over back to you.
Great, thank you. So for the next two examples, there's more buttons to click these days. There we go. So this one here, again, we're sticking with this. And if Carol Ann mentioned, we did some last time. So if you missed that session, you can find it on YouTube and you'll find that there's other examples showing the different types of reports that we can quite often receive relating to temperature. This one is decreased sensitivity to heat, resulting in burning mouth. And if you think back, we saw one perhaps related to this in the last session. So what is the patient feeling here? Decreased sensitivity. Is this a recognized medical condition? Well, as Carol Ann told us before, sensitivity relates to a neurological issue. Sensitivity, that's what you automatically think of where you see that word. What is the result affecting the mouth? Well, what's going on here? Decreased sensitivity in resulting in burning their mouth. And so based on that, what LLT or LLTs would we choose? When I look at that, I think there's two elements here. There's the decreased sensitivity to heat, and then there's the burning of the mouth. So these two things are what I have in my head when I first see this example. What would you code it to? So oral temperature sensitivity, heat sensitivity, thermohypoesthesia. And as I say, if you were here last time, you'll remember we talked about what these are. Carol Ann just told us when she showed us her list of different types of terms. Hypoesthesia oral, burning mouth, burned mouth, or burning mouth syndrome. Okay, so I see I'm watching the votes coming in. I'll move on just so we can see how your thoughts are coming in. The most popular choice is thermohypoesthesia. 20, and some of you are changing your mind here. Oral temperature sensitivity, a few of the others have been selected. And then with the burning mouth is the most popular one of the three I gave you here. Burned mouth is this coming along second, and not so many of you burning mouth syndrome. So that's close the pole, thermohypoesthesia. So let's browse MEDRA and have a look at the terms that we've mentioned there. So we talked about sensitivity. So let's look at sensitivity and heat and see what we see. We got heat sensitivity. Let's look at the hierarchy of that. That's a temperature intolerance. That means the person's overly sensitive to heat and it's under feelings and sensations. Well, that seems more of a whole body thing rather than a temperature intolerance, rather than what we've got here is that they've got decreased sensitivity to heat. I'm going to do a search on aesthesia because that is where we think of paresthesia, hypoesthesia, and then we saw our term thermohypoesthesia. We've got anesthesia. Let's have a look at the hierarchy for that. Caroline showed us cryesthesia on her list before. Cryesthesia is a thermohyperesthesia, so it's an excessive sensation or sensitivity to heat, and in this case it's cold. Cryo means cold, frozen, so that's where this is a particular condition where thermohyper, being overly sensitive to cold temperatures. So what we've got is they're under sensitive to they've got a decreased sensitivity. So let's see if we've got a hypo or hypoesthesia to heat, thermohypo or hyperesthesia, sometimes called. Let me zoom down. Don't get seasick while I zoom down. Thermoanesthesia, thermohyperesthesia, thermohypoesthesia. There it is. There's the equivalent one where they've got a decreased sensitivity to cold. So that seems like quite a good choice. I'm going to go to the browser to have a look at that one. So there was nothing we saw oral there. Where is our term that we... thermohypoesthesia, is it? There it is. It's highlighted for me. Thermohypoesthesia. No mention of the mouth there. So I can go back and I can have a look, not specified to, I can put oral in here or mouth and see if there's anything else that comes up. To anything better. We've got anesthesia oral, so lack of sensation. This is just general sensation, lack of or abnormal sensation in the mouth. Paresthesia oral dysesthesia, so perhaps an unpleasant sensation in the mouth, but nothing relating to the temperature. So I can either capture the site of being oral with an abnormal sensation, or I can capture the more specific thermohypoesthesia, decreased sensitivity to heat. And based on those two, my preference prefers to capture the specificity of the condition and not the site. And that's something that we're advised in the points to consider. Always capture the specificity of the condition in preference to the site if you can't capture both. So now we're going to have a look. I'm going to have a look at the burn mouth. So let's have a look here. We had 3 in our polls. Burned mouth. Let's start with that one because it's the top of the list. The other one is non-current. So burn of oral cavity. So it's actually a thermal burn, burned mouth. We've also in our list here burning mouth. Burning mouth is a burning sensation under a PT of oral discomfort. So that's showing there's a sensation in the mouth. And then we have burning mouth syndrome. Well, I'm always a bit wary, a bit cautious choosing syndrome terms because that's definitely a diagnosis. And a syndrome is more than just one symptom. It's a more encompassing group of symptoms or clinical signs. We don't know that. We don't know our person has that. And it's oral soft tissue signs and symptoms. So that's something I would want to research before choosing. So looking at my verbatim, which was decreased sensitivity to heat resulting in burning mouth, Most of you, or the more of you, chose burning mouth, but as we see, that's a discomfort, that's a sensation. My thinking was it was more likely to be a thermal burn, because if the person doesn't have the sensitivity, they have a hot drink and it causes a thermal burn. So that's where I was, my thinking was lying. So let's go back to the slides. Let's look at some references. Well, burning mouth syndrome, first of all, we said that it's a syndrome. It's more like a diagnosis. We're going to be cautious about choosing it. Just for completeness, I'll show you a reference we found that shows it's strictly defined as a burning, painful sensation in the mouth with normal clinical examination, no obvious organic cause. So this is something very specific. It's thought to be neurological. It is a diagnosis. It would be an absolute assumption, and it would be wrong for us to select that. Now we have one. The previous example we saw was in the last session. This is the slide we've carried forward. Thermohyperaesthesia is a dysesthesia marked by increased sensibility to heat and cold. So sensitivity, sensibility, synonym there. Or the opposite of that is thermohypaesthesia or thermohypoaesthesia. Both of them used synonymously. And this is a dysesthesia marked by decreased sensibility or sensitivity to heat and cold. Thermohypoaesthesia. So this is what we've got reported here in our reference. Now we think about our intraoral burns. So what is an intraoral burn? What does this article? Well, I've summarized it here for us, that a thermogenic burn arises from latent heat transfer to the oral mucosa upon contact with high temperatures. So this is what's happened here. They've decreased sensitivity to heat. They've probably had a hot cup of tea or a hot drink, hot food, and it's caused a burn in the mouth. Not just a sensation of burning, but an actual thermal burn. This does happen after accidental ingestion of hot substances, often in pediatric patients, and it can cause a superficial or partial thickness burn. It's an actual burn, a vesicular or ulcerative lesion, not just a sensation of burning. So I think using a judgment, I would then look at this being a thermal burn. That confirms what I thought I saw when we first looked at the term. We would ensure that all the elements have been captured, both the decreased sensitivity to heat in the mouth, as well as the thermal burn, the burning mouth. Use judgment to select an LLT there, and I'll be interested to hear your comments on this one, seeing as so many of you voted for burning mouth. Consider synonyms like aesthesia, prefixes and suffixes, aesthesia, thermo, hypo, hyper. Always think of those when you're looking at the MEDRA terms, and use medical references as you've seen us do. So I would end up with thermohypoaesthesia and an LLT of burned mouth, which has a PT of burn oral cavity, a thermal burn. So any comments on that one, Carol Ann?
Let me check. No.
No. Good. I'll move on to the next one, and we can always come back if we need to. This is our last temperature example. We really enjoyed doing these temperature terms because it was interesting how many areas of MEDRA were affected when you start looking at the various reports. Now we've got another interesting one. Temperature decreased to 39. So what's going on here? Decreased, but it's 39. So this again is one of those, you see it and your brain automatically looks at it and says, well, what do you mean temperature 39 decreased? And it doesn't give degrees, it doesn't say a scale, a range. But so what is being reported? Is it body temperature? Body temperature 39 would look to be high, I would have thought, if we're talking degrees Celsius, degrees centigrade. There we 39. Is it product storage? Should we think not stick in the groove of where we immediately think? Is it increased? Was it originally higher and it's come down to 39. Do we need to seek clarification on it if that's the case? And it's confusing. So looking now at the MEDRA term selection points to consider, the first guidance we've picked out for you is that when you have a lab result, you should code it to something within the investigation system organ class. And when you have a report of a condition, it should go into the body system disorders. Like here we see hypoglycemia is coded to metabolism and nutrition disorders. So then that's their first bit of guidance. Here we see 39 suggests that it's some sort of measurement. So I'm thinking immediately then of an investigation result. The points to consider also mentions that if it's an unambiguous investigation result and you have the units, then you may choose to code it to something like glucose low, the qualitative report, the qualitative corresponding LLT. If you have all the units and you're clear that it's an unambiguous, clearly outside of the normal range. If it is ambiguous and you don't have the units, you need to be cautious. And here you see with the example of glucose, when you have glucose 40, it's coded to glucose abnormal because we don't know if that's a high reading or a low reading based on not having the units and what scale has been used. So that's the points to consider guidance. I'll look now at body temperature. So we were told it's 39. So let's reference. I'm thinking that's high, but let's check that out. Normal body temperature is generally accepted as in degrees centigrade. It's 37 degrees or 98.6 degrees Fahrenheit. Some studies have shown that normal body temperature can have a wide range. And as Martin's already told us, it can vary by time of day. It mentions that here as well. A temperature over 38 means you have a fever, maybe caused by an infection, and it does vary throughout the day. So that's, again, tells us that 39 seems to be high, which decreased is strange. What about, could it be that it's the temperature storage of the medication? Unlikely, but let's just check that. So we found a nice reference here showing that medication storage temperatures are recommended by the United States Pharmacopoeia to be maintained between 15 and 30, which is 59 and 86 in Fahrenheit. So that wouldn't match either, the 39 that decreased, so that wouldn't fit either. So I think I can rule that one out. So based on that, what would you code? Now's your chance to give your own vote. Is it the body temperature abnormal? If we look at the PTC guidance, where if you don't know it's conflicting, if it goes, you go abnormal, or is it decreased because it tells us clearly that it's decreased in the verbatim term? And if it says it's decreased, do we code body temperature decreased? Do we code a high temperature because 39 would be a high temperature? There's not that much variation in the possible units there. Pyrexia as a fever. And then is it a feeling of temperature change? Pre-existing condition is improved, maybe? Wow, that's a bit of an interpretation. Or do we seek clarification? So I know you're still voting, so go ahead. Oh, overwhelming here that the group would like to seek clarification. And I'm pleased to see that because that's good to see. You are being cautious. No, we mustn't make assumptions. Few of you would code body temperature abnormal. That's maybe if you can't get clarification, or body temperature decrease because that's what it tells us in the actual verbatim term. So I'm going to close the poll. We can have a look in the browser. I'm not sure what else there is really to look at there by looking in the browser, but we can have a look at the where their terms are placed. Body temperature abnormal. That will be in the investigation SOC. Let's see what we have. If we do body temperature abnormal, decreased, increased, feeling of body temperature change. Well, No, that's not what we've been told. It seems like this really is, the numbers tell us that it is a result. I think the question, though, is if it says it's been decreased, do we choose this body temperature decreased on the assumption that the patient temperature may have been higher, and so relative to baseline, it is decreased? However, temperature 39 is not a low reading. MEDRA isn't used like that. I think Carol Ann and I would both agree that MEDRA isn't used for coding relative results, that it's relative to the patient's baseline. When you have readings like this 39, so you have to be cautious about taking too much interpretation in the context of the patient. So that's something I would just be cautious of. We can see there that these are lab results. Pyrexia would be a diagnosis, so we won't go for that one. Feeling pre-existing condition improved. So I don't think we won't spend any more time in the browser. Let's go back and use our time more sensibly there on the slides, see where we're going. Distinguish between reported laboratory results and medical conditions. So saying that, we wouldn't code it to a fever, although 39 in centigrade would be a high result. If it's reported as a lab result, we code it as a lab result. Don't select your MEDRA terms based on a relative to an assumed prior baseline. That's what I've just mentioned. So we wouldn't say, well, because it says the temperature's decreased, we would take it that the patient's temperature was probably higher, because it could be that it's a transcription error, it's been copied wrongly and it should have been increased. Maybe the handwriting's been misread, or it's been an error somehow, or the 39 might be wrong. So it's hard to say there when you have a conflict of information. Be careful when you do have any conflicting information, like a qualifier and a result, and that's what we saw in the MEDRA term selection points to consider. So based on all of that, I agree with you that the first point of action would be to seek clarification. Has there been a misentry? Was it previously higher, or has there been an error in the transcription somewhere? And if we can't get any information, exactly as you suggested, we would code to body temperature abnormal. So any comments on that one, Carol Ann, or on the previous example?
No comments at all. We have a silent audience today. Or it's everybody's agreeing, maybe.
I think so. From the voting, everyone was there before I was on it. Thank you, Michaela. You're smiling or laughing that you agree. So I'm really pleased to see that. Good. Okay, I'll hand back to you, Carol Ann, for our next set of examples. That's good. We're getting some positive feedback. Very nice. Thank you.
So here we are with the next verbatim. Here it is reported in patient's medical history. It is reported that an ulcerated lesion on the right inner ankle is in the stage of scab formation. Let's again first look at the verbatim. Is the information clear and sufficient for coding purposes, or do we need additional information? Is clarification needed? Is split coding required to capture the full information, or can we prioritize parts of the information received? And once we are clear about how to proceed, only then we would start searching for suitable MEDRA terms. So how would you approach this verbatim? Medical history of this patient: ulcerated lesion in crusting phase on right medial malleolus. Is it a skin ulcer, chronic skin ulcer, ankle ulcer, crust, ulceronecrotic skin lesion, or would you seek clarification? Would you assign one code? Would you split code? Would you seek clarification? What would you do? Now I see you voting. So let's see what you're going for. Ankle ulcer is the most popular assignment. Ulceronecrotic skin lesion as well. Skin ulcer, many of you would also see clarification, or what you would split coat and also capture the crust. So let us close and let us look at the reference again. DermNet is always a good and reliable source of information on the internet when it comes to skin diseases. So here's a more detailed explanation of the terms acute and chronic skin ulcer. Chronic skin ulcer was one of the options in the poll. An acute ulcer should show clear signs of healing within less than 4 weeks, including crusting. Crusting phase is the healing phase. A chronic ulcer lasts longer than 4 weeks and is often associated with venous insufficiency or chronic arterial insufficiency, diabetes, or hypertension. Neither of these is described in our verbatim, so coding our verbatim as a chronic skin ulcer would not be correct. We would be adding information to the coding that we did not receive. Crust and scab are used synonymously in English, as you can see in Dorland's here. A crust protects the underlying wound, in this instance the ulcer, and is usually an important step in healing. However, of course, discoloration of the crust, new secretion, or enlargement of the ulcer may occur, for example, due to infection. But this has not been reported in our case. The description in our verbatim about a crusting phase rather refers to the normal healing process of the skin ulcer. The meta-term selection points to consider document clarifies that we should only split terms if doing so would capture relevant medical information. And we see some examples of this here. So diarrhea and vomiting, of course, are two different concepts, two different PTs. We would split code. Wrist fracture due to fall. Again, we would split code because the fall may be drug-induced, inner ear disorder, neurological problems whatsoever, hypotension. BRAF, positive malignant melanoma. BRAF gene mutation is an important information in oncology. It's relevant for the treatment and also the prognosis of patients. So this needs to be captured. This is an important information that needs to be captured. So let us look into the browser again and see whether we can find how to approach this verbatim here. So if I enter ankle ulcer and crust, so keeping to what we have in the verbatim, nothing. So if I delete the crust and just search for ankle ulcer, because the right malleolus is of course at the ankle, I find ankle ulcer, and ankle ulcer is grouped under PT skin ulcer. So right mouse click, go to browser. Let's explore this PT skin ulcer here. Here we are. Oops, quite a number that we see here. So we have chronic, we have the ankle ulcer at first. Do we find anything that relates to a crust? Malum perforans pedis, nothing with a crust. So the most specific term that we can find under PT skin ulcer is really ankle ulcer. So if I now search for scab or crust, this was the wording in our verbatim. Here we have eye crusting, eyelid margin crusting, nasal crusting, and one LLT crust that is grouped under PT scab because both can be considered synonyms. Let's see whether we have, go to browser, whether there are LLTs under this PT, which could be suitable for our verbatim. Scabbing, scab crust, so nothing that would relate to an ulcer whatsoever. So when you look at the hits that we see here for crust, you see mucosa erosion crust. So it's an erosion, it's not an ulcer, it's an erosion with the information crust. So let's see what this is all about. Go to browser again. It's of course a different medical concept. It's just an erosion. Mucosa erosion crust. We see that the crust information is really lost on PT level. Mucosal erosion, here it is. So the crust here is really a normal feature of an erosion or an ulcer, so in a healing process. So that's why also MEDRA does not consider the crust on PT level, but it's just only mentioned or represented on LLT level. So let me go back to my slides. Here too, it was advisable to refer to medical literature in order to better understand the reported crusting phase that was described in our verbatim. And only then one should start searching in the browser. And if no suitable term can be found that covers all the information, one must decide whether split coding is necessary or whether parts of the description can be prioritized in a meaningful way. So, and we came to the conclusion, our final suggestion is to really only code to ankle ulcer under PT skin ulcer, because the crust can be considered a normal feature of an ulcer that is healing. And no one of you has selected the crust LLT, so nobody has considered split coding here. I think that querying is also not necessary. It's a very clear verbatim. So in my view, ankle ulcer and is sufficient to code, so there is no split coding is necessary. Do we have different opinions, Jane?
I don't think so yet. Caroline, just let me know. All the comments we've had are on the previous examples, so.
Okay.
Nothing. Oh, hang on, here's one. Could we also code fracture of medial malleolus closed?
No, it's a fracture. That's a completely different, it's a fracture, so a bone fracture. It's a bone disorder, an injury of the bone. Here we have an ulcer, and it's a skin ulcer on the ankle. So that's why this would not be appropriate.
Okay, thank you very much. No, that's the only one we've had on that one. Thank you. And we've had a thank you for that response. So no, we've had several on the previous examples. So carry on, Caroline, and I'll deal with my examples when I take over.
Okay. So next one, thromboembolism of upper extremity artery is reported. I think this is a very clear description again of the event, so we can immediately start looking for a suitable LLT. And ideally, we would try to find a MEDRA term that combines this information, meaning that it should cover both the thromboembolism that was reported and the affected body site. So what would be your approach here? Arterial thromboembolism, arterial embolism and thrombosis of upper extremity, arterial embolism limb, embolus upper extremity, thrombosis arterial arm, or would you seek clarification? What would you do? Like always, plenty of options in MEDRA. So thromboembolism with the affected body site, meaning upper arm. And it's an artery that is affected. So most of you are going for arterial embolism and thrombosis of upper extremity. Others are arterial thromboembolism, but and a few also arterial embolism limb or embolus upper extremity. So we have a split of opinions, but arterial embolism and thrombosis of upper extremity seems to be the preferred coding approach here. So again, let's look for these terms in the browser. So if I look for thromb and embolisms, just using word stems, and then arm, because it was the upper arm, nothing. So I can now use synonyms, broader terms like limb. And here we have the arterial embolism and thrombosis of upper extremity. This was one of the options of the poll. You can see it's in non-current LLTs. And of course, we should not assign non-current LLTs in operational coding. So why is this term non-current? Because it does not tell arterial thromboembolism of upper extremity, but it contains arterial embolism and thrombosis of upper extremity. So it's two events here. It's embolism and thrombosis. So it could be an arterial embolism and a venous thrombosis whatsoever. And that's why this term represents two separate concepts, and that's why it's made non-current. So otherwise, no other options. If I replace limb by extremity, again, only these three non-current LLTs come up. So now let's search for thromb and embolism. And here we have the arterial thromboembolism. So we know that an artery was affected by the thromboembolism, but we don't find anything that relates to the arm. We saw that before. So let's see. Arterial thromboembolism, of course, is the main concept. Let's see and go to the browser what we can find there, whether we can find a more specific term that would capture the affected site as well. What we see is that arterial thromboembolism is grouped under embolism arterial. So the main concept is the embolism here, the embolism of an artery, and that's of course interesting. That's why it's always really useful to look into the hierarchy of MedDRA. We can take this approach in MedDRA as a guidance and just code or search for an embolism. So let's get rid of the thrombosis. Just search for an embolism of the arm. And here we have the embolus arm. If I go to the browser again, you see that we have a peripheral embolism, not only the one that we saw before, embolism of the artery. We have a peripheral embolism as well. The other one was, where is it? It's a group even on a different HLT, obviously. Embolus arm would be one option, but embolus upper extremity is closer to our verbatim. So here, with this LLT, we would capture the specific, the event that happened, the condition, and the affected site, the upper extremity. There's no more specific term which would cover the upper extremity, the upper arm, but here we have the upper extremity, so the arm is affected. We could at least capture this information. So with this, How did we proceed here? First of all, we used word stems, synonyms and quasi-synonyms for our search to not overlook any suitable term in MEDRA. We then used the MEDRA hierarchy as a guidance for our further search when we could not find a suitable term for its thromboembolism of the upper extremity. Namely, instead of searching for thromboembolism, we searched only for an embolism in the arm. And in similar situation, when no exact match is found for the affected limb, either leg or arm, then search for more general terms such as limb, extremity, or also peripheral. And here's the proposed coding. We would select embolus upper extremity under PT peripheral embolism. Any questions, Jane?
Yes, we just had a question about what about the thrombosis? Could you explain again why you're not worrying about capturing the thrombosis part?
Yeah, because you saw that in MEDRA, the thromboembolism, so it's the main event is the embolism, so that an embolism has occluded the artery in the arm. So there's a thrombosis because of the embolism, but the main event is the embolism. It was just not only a thrombosis. The embolism has caused the thrombosis, the occlusion of the upper extremity artery. And this is also the approach of MEDRA. You saw that thromboembolism is grouped under PT, LLT thromboembolism is grouped under PT embolism. And all peripheral embolism, each embolism in the periphery of the body is always arterial. Any further questions?
No, that's the only question on that one. Thank you, Caroline.
Now it's a more complicated one. You saw that if you looked at it, you got the verbatims in advance. So if you looked into it, you may not even have known what to do with it. Bleeding at distal leg perfusion. Again, something that we got from a MEDRA user. So it's a real life example, real life verbatim. So let's first look at the verbatim. Is the information clear and sufficient for coding purposes, or do we have to seek further clarification? Are we clear about the type of bleeding and the affected body site? Do multiple MEDRA terms need to be assigned to capture this information? Is split coding needed? And can we find a suitable LLT or LLTs? Bleeding at distal leg perfusion. So what would you do with this one? I admit it's a difficult one. It's challenging. It also took us a while to find out what this is referring to. Would you assume a poor peripheral perfusion? That's why the leg was perfused. Would you assign catheter site bleeding, vascular access site bleeding, medical device site bleeding, vessel puncture site bleeding, or implant site bleeding? So there was a bleeding, that's clear. It was a local bleeding that was connected to a procedure, kind of procedure. But which of these LLT to assign? Catheter site bleeding, vascular access site bleeding, medical device site bleeding, vessel puncture site bleeding, implant site bleeding. Lots of options. Vascular access site bleeding is the preferred one, followed by medical device site bleeding. So some of you would also code the poor peripheral perfusion. So let me close the poll. Yeah, it's confusing. So it's one does not exactly immediately know what to assign here. Vascular access site bleeding is the preferred option that you selected. So let's look what this is referring to. We need to better understand the medical context of the reported distal leg perfusion here. The verbatim refers to extracorporeal membrane oxygenation or ECMO. It enables oxygen enrichment of the blood and simultaneous carbon dioxide removal, and is therefore used for temporarily bypassing pulmonary and/or cardiac functions. Severe pulmonary failure is the most common indication for the veno-venous approach here. You see there are two different approaches: cardiogenic shock and cardiopulmonary resuscitation for the veno-arterial ECMO. So what happens is that the blood is taken out of the body with a pump, it's oxygenated, carbon dioxide is removed, and then it's reinfused. Here it's reinfused into the body. Veno-venous, and in the arterial here it's taken out and then reinfused in the in this opposite leg. It's reinfused into the circulation. When using the veno-arterial approach, many patients experience local complications at the site of the percutaneous vascular access, which can lead to reduced blood flow in the cannulated lower extremity. Because the main arterial cannula impairs distal perfusion by compromising the lumen, potentially causing leg ischemia. So there's a high rate of cannulation-related limb complications in ECMO, sorry. In order to restore perfusion or prevent such complications, it is therefore recommended that an additional perfusion cannula be inserted into the femoral artery distally to the cannula used for the ECMO. So you see that here. Here, the blood comes, it's retransfused into the patient and the femoral artery. And here is this little additional cannula that is perfusing the limb where the cannula is inserted in. So in this way, either treating or preventing leg ischemia due to occlusion or semi-occlusion of the lumen of the femoral artery. So it's a routine procedure in ECMO. So let us look for suitable verbatims. Poor peripheral perfusion. So we don't know whether there was already a poor peripheral perfusion. This would be an interpretation. So this peripheral leg perfusion may also only be performed for prophylaxis, for prevention of leg ischemia. So this would have been an assumption and would not have been correct code assignment. So let's look for the site bleedings. One was catheter site bleeding. Here we have catheter site bleeding. Go to browser. Here we are. We see this, it's grouped under administration site reactions, implant and catheter site reactions. So here, yeah, the blood was reinfused, but there was no administration of drugs or fluid or electrolytes whatsoever, or there was not a blood puncture of a vessel in order to take out blood for investigational purposes. Implant site bleeding was the other option. Oops. No. So the term implant refers to artificial materials or products that are inserted into the body and remain there permanently, or at least for a longer period of time. And again, this is not the case here. If I click on it and say open details and occurrences, you see that it is also grouped under administration site reactions. Implant, next one was medical device site. Search. Here is it. Here we are, open details and occurrences. Again, it's grouped under complications associated with device. So a different HLT, not administration site reactions here, but a medical device is too general. It could relate to a pacemaker, etc. What is reported here is a vascular procedure. That's clear. It's a vascular procedure. So medical device site bleeding would be a bit too vague. So vascular access site was the other option. Here we are. And again, open details and occurrences. And here we see that this vascular access site bleeding is grouped under cardiac and vascular procedural complications. So this is the correct HLT because we have a vascular procedure here. It's the ECMO. And we have a complication due to this procedure. So HLGT, procedural related injuries and complications, NEC, is a suitable HLGT in this instance. And vessel puncture site was the last option. And if I click on it and say open details and occurrences, you see that it's also grouped under administration site reaction. So what can we take from that? First of all, here again, the options that we had, and actually the vascular access site bleeding really best describes what has been reported here. It's a complication of a vascular surgical intervention, the ECMO. If no additional information can be obtained, then one has to rely on the verbatim, and most probably it will be necessary to consult medical literature in this instance in order to better understand the reported event. And when searching for suitable terms in the browser, you should use top-down and bottom-up searches, and always different approaches, and always check the hierarchy to see whether the respective term really is correctly captured, whether the hierarchy captures the reported event in a medically meaningful way. And we could also see that there are many coding options in this area. And therefore, it is really advisable to provide guidance in your internal coding conventions to ensure consistent coding of similar reports. So here we would code to vascular access site bleeding under PT vascular access site hemorrhage. And most of you have voted for it. Very well done.
Very well done. No, yeah. That was a very hard one, Caroline. People did well there. A couple of comments. One is that looking at that term, some of our attendees said they would query it straight away, that they do want more information to be sure on this one. Unless you're working in a specific area. Another comment that you need to really have medical knowledge and be willing to do some referencing to do accurate coding. Coding is not always straightforward, and you do need expertise. And then we have a comment on your previous example. That's all we've got on yours so far. Mm-hmm. The previous example, going back to the thromboembolism of the upper extremity artery, the comment is that if you don't capture the thrombo part, the fact that the embolism is a blood clot, you're losing information, because an embolism could be other things. It could be other material like a fat embolism or other types of embolism. So the feeling is that thrombosis part is important to capture, even though you showed us with the hierarchy of MEDRA, it doesn't get captured at the higher levels. Our attendee thought that it was important to capture.
I understand your concerns, but on the other hand, you would not split code, because we saw that there we would try to code the fact that the arm was affected. You saw that it's really a difference on PT level. It's a peripheral embolism, and you would usually try to capture this as one event. And an embolism per se is already, when it's an artery, it's an occlusion of a vessel. It may have parts or may have components of a thrombosis as well, because the embolism is stuck in the artery when it gets narrower and narrower and narrow. So it stuck there, and some thrombotic aspect may be there as well. But the main event is the embolism, occluding the vessel.
Thank you, Caroline. That's all the questions we've had on those. We had some questions relating to the earlier temperature terms that I presented. We had some comments about the temperature decreased to 39, why we didn't take temperature decreased, because it could be relative to the patient having a higher temperature previously. So temperature decreased to 39, why did we not choose that? Because isn't abnormal an interpretation? And I gave the rationale in writing that we see it as being ambiguous, because it does say 39 and it says decreased. And unless you have information about that patient to know categorically that it is a decrease from an earlier higher temperature, I can't be sure that decreased is correct in the verbatim. There could be a transcription error. And based on the PTC guidance, that's why we chose abnormal. We also had a comment, we had difference of opinion between a couple of our regular attendees between whether the decreased sensitivity to heat resulting in a burning mouth, whether the decreased sensitivity to heat is better to capture the site, an oral dysesthesia, oral hypoesthesia in this case, rather than thermohypoesthesia. Do we capture the specificity of the condition or the site? And that is we could have a debate, I think, amongst our audience today on that question. We chose to go for the condition, but that's I'm having comments, conflicting comments from different attendees from our regulars.
The PTC guidance document is very clear on that. So telling us that the specificity of the event always takes priority over the exact localization. You find it in the points to consider document.
Do you think we can fit one more in, Caroline? Do you think we can do a quick one to get to our 8? Let me go through this one quite quickly then, and so that we can give you the chance of 8 examples today. Our next example is CMV replication, a nice short example here, but what is being reported? Is this an investigational result or a diagnosis? And that's a question we've asked today on previous examples. Do we need to get clarification here to really understand what is being reported? Is it a result of a test? It doesn't look like a test, but what is it? Now, bear with me, I have to do, there we go. So how would you code it? Is it viremia, CMV, cytomegalovirus? I think we can be happy that if we were to look up in an abbreviations book, it isn't a perfectly acceptable and clearly unambiguous abbreviation. So is it viremia? Is it infection reactivation, infection, reinfection, antigen positive, DNA test positive, viral load increased without capturing the specificity of CMV, or do we need to query? I'll show you where you are just in the interest of time. You can carry on voting. A number of you would like to clarify that to find out exactly what is being reported. I agree with you there on that one. It isn't clear to me immediately what is being reported. If you can get more information, try to get more information. That would be the first action. And let's see, if we can't get anything better, what would we do? Well, I'm going to move on, show you a couple of references. Firstly, just to let you see that CMV is a widespread human pathogen. It shows that seropositivity is greater than 90% in some populations. And what's interesting, I hadn't realized actually, is that it does result in a lifelong latent infection. So it's a bit like herpes in that way. It never actually goes away. It just goes latent. It just goes dormant. So that's why we're seeing the LLTs of reactivation there as an option, not necessarily reinfection. So that's something to bear in mind. The second reference is that the quantification of CMV is done through DNA in blood samples. And this is the gold standard for identifying active viral replication. So there's that word that we have, and it seems to be related to the way the test is done, something that's measured, identification of active viral replication. So that makes me think test result when I see that. And DNA is mentioned as the way that the quantification is done. So we can have a look in the browser. We don't have a lot of time, but we can have a look just to see some of these terms, the placement of some of these terms. So if we look at CMV viremia, that was in our list of polling. CMV viremia, I'll show you the hierarchy. That one comes under cytomegalovirus viremia, is under cytomegalovirus infection. So we've got the cytomegalovirus infection, but then we had some others, didn't we? We had some other options. We had reinfection, reactivation. So let's see the placement of these. Reinfection. Well, we haven't been told it's reinfection. Reinfection suggests that, cytomegalovirus. Reinfection suggests that the patient has been reinfected another time rather than a reactivation. Cytomegalovirus reinfection, that's again under the PT of cytomegalovirus infection. So it seems like our patient must have the cytomegalovirus either active now or they have had it in the past. Cytomegalovirus reactivation. Let me put this one now. Let's look at the placement of this one. This one is reactivation, again under the, so it's got its own PT as reactivation, but it's still under cytomegalovirus infections. So we can see that if we go to the browser, we can see the group of terms there. It's their own PT, and it's the only LLT underneath it. So this is where, these are all the conditions, all the types of infection, but the fact Dal said replication makes me think it's maybe a test result. So we could have a look for cytomegalovirus DNA. That was another one, cytomegalovirus DNA test. Cytomegalovirus DNA test positive. So it's testing for the DNA in order to see that there is an increase and a replication. So an increase, but it is testing the DNA based on the reference we saw. But that doesn't really capture the increase, the worsening or the increase. So the last one I'll look up is viral load, and let's see what terms we have that capture, because it seems like it's an increase in the viral load. So we have HCV, HBV, hepatitis virus infections, SARS-CoV-2 viral load, but we don't have a viral load increase for CMV. which is what would be our ideal, I think, in this. Replication suggests that the viral load is increasing, but we don't have one. So we would either have to choose a viral load increased without capturing the CMV, or split coding it to the capture CMV separate, which would be a bit over coding really, or we have to look for one of the other test results. So I'll go back to my slides. I'm just looking at time. I realize we're out of time. We know here we've already seen the difference between coding a lab result when it's reported as a lab result. And here we saw in the browser the difference between choosing something that we know is an infection, whereas a lab result, if we're clear that our verbatim term is reporting a lab result. And under cytomegalovirus test positive, you have the various types. You have the antibody and the DNA, the antigen, the ones that I showed you there. And then we have the viral load terms that we can't capture the specificity of the virus if we were to choose that. So what we would do here learning is we would get clarification from textbooks. We showed you a couple of references. We would distinguish investigational results, very important there, from the diagnoses. Consider the MEDRA hierarchy and where the terms are placed. Use synonyms and quasi-synonyms, so CMV, cytomegalovirus, reinfection, reactivation, different concepts there, and provide guidance for such coding scenarios in your in-house coding conventions, particularly if this is an area where you are working a therapeutic area. So those are our main learning points. We would seek clarification, like you said in the poll. I agree with you to ask, is this a lab result? Is it saying that the viral load has increased? Is it an increase in the DNA, the replication as we saw from the reference, or is it a diagnosis of a reactivation or reinfection? Is the reporter telling us a diagnosis? Unless we follow up with them, we can't be sure. If no information can be obtained, we would code it to cytomegalovirus DNA test positive, and that's based on the reference we found, but that's only if we can't capture any more information, because we don't feel confident in saying, is it reporting an infection, a reactivation, a reinfection, viremia, what is it? So that's why we would err on the side of caution and go for what is something under the PT of cytomegalovirus test positive. So that's that one. Let me just come out of this and I'll go to show you our wrap-up slides whilst you see if we have any questions, Carol Ann.
No questions.
No questions. So I'm going to open the survey for you now. We do an instant poll survey here. This is your opportunity to tell us what you thought of the session. You'll also have a survey sent to you. Here, in this one, you can tell us if you want us to look at a particular topic or you want us to have a look at coding one of your examples that you may have had challenges with in the past. So that's where you can show us what you want us to look at next time in January. This is our YouTube channel. We mentioned this a couple of times. We do record all our sessions. This is session 32 today. So you'll see there's a lot of examples there over the last 5 years we've been doing it. 5 years, my goodness. This is our contact page where you can get to the YouTube channel from here, and you'll find a playlist. And there's also on our training materials page, you'll find there's an index and you can get a list of what verbatim terms were covered in each session. And if you have any trouble with that, just send us an email to the help desk and we can point you in the right direction. Here are the links, and I realize I'm over time, so I'll leave the links on the screen for you if you want to look at the browsers or the help desk email. Any questions, Carol Ann?
No questions.
That's great. Well, thank you all for your comments today. Thank you for the interactions, the voting. Thank you, Carol Ann, for your medical expertise on these terms and for our collaboration. So
yes, thank you, Jane.
It's
always fun.
Always fun. We enjoy it, I think, as much as the audience. We won't have another session with you now before the year end celebrations. So although it's early, we do wish you all the best and have fun over the end of year celebrations, wherever you are. And we will look forward to seeing you all back in January, where we will cover the 2 examples we didn't have time for today. So thank you all. Bye-bye. Take care, everyone. Stay safe. Bye-bye.
Thank you. Thank you. Bye.